Pronto? Sì. Ci farà vedere anche lui una sezione dal vivo e ci parlerà, quindi vedremo un gel di agarosio con un global face con gel di agarosio. Ok, buon lavoro.
Tu dici sei il presentatore o la valletta?
No, faccio la valletta.
Ah, ecco.
Posso la valletta, sì.
Good afternoon, everybody. No, mi dispiace, no.
English?
Yes, I'll speak as slowly as I can. I'm Johan Vandeputte, I'm Flemish, I'm from Belgium. I've been asked to do a demonstration, volumizing injection with agarose. The brand name is Algenes. It consists of agarose particles and it is compounded with a very light concentration of non-cross-linked hyaluronic acid, only 0.5 milligrams per mil to make the product more fluid. Now, before I introduce the patient, I would just like to make clear that when I do this, I am not compounding the product with lidocaine. The product comes as such, and the only reason we do this mechanical gesture is to make sure that it's even, that the particles are well distributed, there is no lidocaine. We're going to perform deep injection, and I prefer not to compound for two reasons. If I happen to inject a branch of, for instance, the infraorbital nerve, I want the patient to punch me in the face before I can actually do that. And the other reason is we're doing volumizing injections deep. What if ever a granuloma would develop? People would probably not accept that I've been compounding the product because that may be a reason why it's contaminated. Right. I would like to introduce Patricia. Patricia, can you sit up for a moment and look straight into the camera? First, I have to make you notice that Patricia has acquired ptosis of her left upper eyelid. Now, anything aesthetic we will do is always, let's say that the ptosis is always going to detract the attention from the filling we do. So I explained to her that this is a treatable condition, that the ptosis can be treated surgically under local anesthesia. She has rather severe loss of volume in the face. I think that the volume of her eyebrows is still quite nice, but there is hollowing of the temples. There is severe loss of volume over the zygomatic arch. There is a show of the orbital margin, and that has been corrected very nicely by her doctor with deep hyaluronic acid, deep injections of small droplets of hyaluronic acid. She has festoons. There are little areas of edema here, and these easily swell when we do large volumizing injections with hyaluronic acid. That is why I think that she is a particularly good candidate to be treated with agarose instead. There is no break here, so all I would need to do is add some volume here over the zygoma and mainly over the zygomatic arch. I would like to make it turn sideways. There is still a nice definition of the angle of the mandible, but nevertheless there is an obvious jaw because of volume loss here and volume loss there. So I want volume over the zygoma and I want volume over the mandibular angle to lift this up. And the last thing I'm going to do is try to push this forward by injection of not 3.5 but 2.5% agarose, because this area tends to get lumpy when we inject it with a high concentration. There we go.
Sorry, but the 3.5 agarose is the highest concentration?
Yes, it comes in 1.5 for superficial injection below the dermis, for immediate subdermal injection, not for intradermal injection. Let me be clear about that. So the 1.5 is excellent to treat marionette lines and to treat the nasolabial folds. The 2.5 is excellent for delicate volumizing, and the 3.5 is fantastic to volumize areas where there is a lot of soft tissue cover. I have already disinfected, so I'm beginning with an injection in the left temporal fossa with the sharp 27 gauge needle. This is about the center of the depression, but let's say we have more gain of what we do when we inject slightly higher. And I'm going in. I'm going to ask the cameraman if this is clear. Is this clear for you? Lovely. There we go. Sorry.
No, yes. Very well.
I'm looking for bone contact, and because I have to make a bolus injection here, I'm wriggling the needle. Because even if there is bone contact, there is always a risk of embolization. If my tip of the needle happens to be in a vessel, I'd rather rupture it than give an intravascular injection. It's becoming painful for Patricia. We have to know that this zone is fibrous. So, if we inject in the muscle, it is not self-evident that we can redistribute product in the fibrous zone over the temporal crest. So while we inject the temple, we have to watch what's happening, and I see that a little gutter is developing. We have to inject that with separate small droplets of gel. I'm looking for bone contact, sorry, there I go again. This is about 0.1. This again is about 0.1. It's enough for this area. I have injected 0.9 now. I'm going to flatten this out and inject the rest of the product deeper in the temporal fossa. There I go again, sorry. Are you all right? Mm-hmm. We're almost done. This is 0.5. It's easy to inject the product, so it's important to go slow. The fact that it's easy to inject does not mean we have to whack in a bolus. You never know. There is always a danger of embolization. There we are. How painful is this? Is it okay? Okay. Could you please just face the camera and you see what we have done if you look at the difference between the left temporal fossa and the right temporal fossa. Usually I add some volume under the brow, but I don't think that Patricia needs that. Now let's move to the injection of the cheek. There is almost excessive volume here, so I'm not going to go in this direction. There is some volume like here, and I like to look where the temporal arches, and this is my entry point. It is the crossing between the imaginary prolongation of the tear trough and the axis of the orbital margin. I'm going to do that with a 22 gauge cannula. And because I'm doing it with a 22 gauge cannula, I need access with an even larger...
Have you used one syringe of
yes.
How many ml?
Thank you very much for asking. I forgot to mention this is 1.4 ml. When I inject here, I'm injecting in the levator of the corner of the mouth. I do not want the filler to be in the middle of the soft tissues which would make the cheek even heavier. I want it to stick to the bone. I want it to be in the origin of the levator, and that is why my first injection is with the sharp needle. The sharp needle is fairly big, not because it's necessary for this bolus, but because I need an entry point for the cannula. You're going to feel this now, sorry. I'm looking for bone contact. I had bone contact, and now I'm just injecting 0.1, 2, 3, not more than that. And we're lucky there's not too much of a bleed. I'm switching to a 22 gauge cannula. And again, I need this to be deep. So I take the entry point, go back in until I have bone contact, withdraw a little bit, and then go towards the temple. I'm so sorry, this is a bit painful. This is deep. This has to be superficial because there is no deep fat compartment over the zygomatic arch. And there is 1.1 left in the syringe. This is a bit painful, and I'm very slowly injecting this by retrograde injection.
You are in periosteal plane.
I am as deep as I can indeed, yes. Because I think that if we inject volume subcutaneously in this area, it behaves like an iceberg in the sea. When the patient smiles, it does not look it does not look normal. And that is a total of 1.4, 0.3 in a bolus, and 1.1 by retrograde injection. It looks slightly exaggerated. I don't want to make 2 or 3 passes if it's not necessary, because that's just poking the patient more for nothing. The product is easy to redistribute. There is still a little bleed, but I think it's worthwhile to make you face the camera, and please sit up so that the cameraman can show your entire face and that you see the difference between this cheek and that cheek. Now I'm going to cheat and walk backwards a bit to observe. Can you see that the jaw is already lifted a bit because we have been pulling there? Please go back again. Now, there is still nice definition of the border of the mandible at the area of the angle. But we have the jaw, and this is a bit flat anyway. So I'm going to inject some volume in the masseter muscle. The parotid gland is here. We have no interest in injecting the parotid gland. We know that the facial artery is running somewhere on top of the masseter muscle, so I really want to feel bone contact, to be sure that I'm in the muscle and not on top of it. And if we don't have bone contact in this area, we may be behind the mandible instead of on the mandible, and that is an excellent position to embolize the external maxillary artery. So I think if we inject this area, we always must be conscious. We are perforating the parotid gland. We are in a dangerous area. I want a sharp 27 gauge needle to be sure that I am correctly in contact with the bone in the masseter muscle. So this is my next syringe of 0.3, and I wonder if somebody could fetch another syringe of 0.2 for me for the last treatment. I'm going to, here's the mandibular angle. You have to palpate. It's not always obvious. Cameraman, can you see that? Yeah. I'm going to inject now, sorry. If this is painful for the patient, it's important that she does not clench her teeth, but rather breathe with the mouth slightly open in order not to elicit more spasm of the muscles. She's being very brave because I have injected 0.4, and after that this invariably becomes painful. I'm going to inject a second point. This is the most dangerous point. I can only do that after, after being sure that I feel bone contact. I keep on wriggling to be sure that if I'm in a vessel, an embolus is not too large, and I'm going to inject the third point here, sorry. I've got bone contact, and there it's going. Because this is a very sensitive area, it's not possible to do retrograde injection. We have to be aware that big boluses can be dangerous. Do everything slowly. You're very brave. Thank you very much.
Sorry, John. I
Yes?
noted that you use this filler in a very deep plane.
Yes.
But this is due to a rheologic characteristic of this filler or for an anatomical...
Both. Both. This is 3.5%. It is intended to last long, but if I would inject the 3.5 filler in this area, in the labiomandibular compartment and in the mentalis muscle, I know from experience that it works, but it feels lumpy for 4 to 6 weeks. So it is more reassuring for the patient if the lumpiness is gone after a shorter time. That's why I use a lesser compartment. So the reason to hit the bone is that this is a safer plane for me than somewhere deep in between, because the major vessels are somewhere deep in between and not on the periosteum. Thank you very much. So now I am taking the 0.2 concentration.
May I ask you why you do this movement with the two syringes before injecting the filler?
Right.
You aren't adding lidocaine or other anesthetic?
Absolutely, absolutely not. It is coming out of the sterile package with two syringes. Okay. If the industry makes agarose without anything else, it tends to clump up a bit in the syringe. That's why a little bit of hyaluronic acid is added. Now, regular concentrations of reticulated hyaluronic acid are about 17 to 22. This is only 0.5 to make the product more fluid. But even in the syringe, it may redistribute. And that's why they make it like this, to make sure that we have an evenly distributed gel just before we inject it.
Okay, thank you. You have 5 minutes.
Excellent, that's just enough to do the last procedure. Here's the jaw that has already been lifted a bit. There is a gap here, and we all lose a lot of bone in this area. So here's my first injection. I'm feeling bone contact, and I'm cheating by hiding the jaw, and this is a bit painful. I have been injecting 0.3, 0.4. I'm injecting again on the chin, 0.1, 2, 3, 4, and I'm going deep subcutaneous in the labiomandibular compartment, 0.3. I warn the patient that even with the 0.2, this will feel a bit lumpy for a couple of weeks, but after that, it's quite nice. A little squeeze to redistribute. I'm going to ask her when I finalize the other side if she likes the dimple in her chin or not, which will make me decide if I inject a little bit into the middle or not. Could you please face the camera again? And now, please zoom out and show the patient's entire face. We see that if we fill the temples well, there is even a little pull on the eyebrow. She happens to have very nice volume of the eyebrow, so I did not treat that. The cheek contour is improved. The mandibular angle is better defined, and these two pull on the jaw. The rest has been hidden by injecting hair. When the little edema caused by the injection is gone, no doubt there will still be a little jaw, but it's definitely improved. This is the foundation. On top of that goes the wrinkle treatment, stopping smoking, and skin surface treatment. Thank you very much.
You reached very good results on the side that you treated.
Thank you.
Very good lifting effect.
Lovely.
And how many syringes and milliliters did you use?
So let's make the count. 1.4 plus 1.4 plus 1.4 of a concentration of 3.5. So that means I have injected 4.2 mils of the strongest concentration. And then another syringe of 1.4 of the intermediate concentration, which makes a total volume, if I'm still with it, of 5.6 mils. The nice thing of agarose is you can get some reactive swelling caused by the injection, but the product itself does not cause swelling. If you inject this kind of volume with highly cross-linked hyaluronic acid, there is a big chance that the face becomes puffy, and I would then do this in 2 sessions. With agarose, I can do it in just 1 session. Remember, we do not have an emergency exit. Agarase is not registered as a drug yet, so I stay away from the orbital margin. For me, it's still a no-go.
Okay, thank you very much in compliment for your results and your technique. Thank you.
You're very welcome. Thank you.
Bene.